esta patología, la de la fibrosis hemorrágica hereditaria. Para ello contamos con Greg Robertson, Diego Balonga y Elisa Prior, en representación de Alnylam. Muchas gracias.
Por favor, que los que tengáis póster salgáis un momento porque quieren verlos ahora, si no os importa. El comité evaluador va a evaluar los pósters. Solo lo de los pósters, los demás que se queden. Son 10 minutos.
So good afternoon, everyone. Good afternoon, everyone. Apologies, this is in English, but my name is Elisa Pryor. I'm here from Alnylam, and excited to have the opportunity today to talk to you a little bit about our company, some of our therapeutic medicine, which is the RNAi, and then share some development plans for our investigational treatment of ALN 6400. So just a bit about Alnylam. We were founded in 2002, rooted in Nobel Prize-winning science of RNA interference. We have our head office in Cambridge. We also have 25 offices in 20 countries, including having an office here in Madrid. And we're obviously very committed to our patients, and we want to develop therapies with the potential for positive impact on patient health to help serve patient communities through education, empathy, and awareness. So this is just a brief timeline of how Alnylam was founded, and then 2006 when our RNAi platform technology became into existence, and moving on to today where we now have 6 approved RNAi medicines in countries across the world. So looking a bit at our therapeutic medicine, the RNAi, this slide is basically just talking a bit about how we alter the gene expression without editing the target gene itself. So RNAi therapeutics are designed with a minimal number of phosphorythretic modifications. It reduces the likelihood of non-specific protein binding that can lead to off-target effects. And some of the RNAi therapeutics are already approved and available to patients. Many more of them are in late-stage clinical development across many, many diseases. So this just gives a bit of an outline about how this works. So we have the siRNA delivered into the cell, where it enters into the RISC and unzips, and then the passenger strand is degraded in the cytoplasm. So moving on then, you have the complementary pairing between the strand and the target mRNA. The guide strand then remains bound to the RISC for multiple cleavage cycles, and then at the end you have the target mRNA cleavage and degradation, which means the production of the target protein is decreased. So in terms of our development plans, as we know, there's many bleeding disorders which don't have any current treatments out there. So our drug, ALN 6400, could potentially treat a wide range of bleeding disorders. We know millions of people in the world are affected by these, and the existing treatments can be burdensome and may have limited efficacy. So to go into this, we have to look at the homeostasis, where obviously modulation of the fibrinolysis may allow the development of a universal hemostatic agent. So our drug ALN-6400 is looking to lower the plasminogen, which will reduce the bleeding. So when plasminogen is produced by the liver and it's circulating, it gets broken down to plasmin, that breaks down the clot, and then we have the bleeding. And we know that we're in the right area since we work on the same pathway as TXA. So it's tranexamic acid obviously provides the validation for the bleeding by inhibiting fibrinolysis. It's approved for treating hepatomenstrual bleeding, frequently used off-label, but there is a high pill burden, effect variability and side effects that limit its use. So when we looked into the UK Biobank, we did some analysis to support targeting plasminogen and bleeding disorders. And sort of there is, which is very promising obviously, there's no evidence of increased risk of thrombosis because we looked at patients that had loss of function for plasminogen, and there was no increase in the risk of thrombosis there. So compared to kind of protein S, protein C, or antithrombotic, you can see if we lower PLG, it's not going to have any increased risk on thrombolytic factors. This graph just shows a quick, if you look at the picture on the right, this is just showing that when we gave our drug to some monkeys, basically reduced menstrual bleeding. So what we've been doing is we've just been doing our phase 1 study in healthy volunteers where we've been looking at 4 dose levels. What we've done is treat the patients with tranexamic acid at the beginning, so they get 5 doses of 1 mg each, and then they'll go on to our drug. So we've got a baseline to compare, effectiveness. So the major, obviously, for this study, it's healthy volunteers. We're looking at safety and tolerability. So in order to look at how effective we are in clotting compared to TXA, we're using a specialised assay called Rotem. And this is basically the picture that you get from it. So you you take the samples and then you administer TPA, tissue plasminogen activator, and then you would see, so there's sort of baselines here where the clot gets broken down very quickly. And then if you give them TXA, it takes longer for the clot to break down. So this is kind of how this is portrayed in these pictures here that we received. So the fantastic news for our drug ALN-6400 is that when we've been doing this healthy volunteer trial, we can see that compared to the placebo doses at the top, when we've given our drug, it stabilizes the clot in a sustained manner. So we're 4 months at the moment from CTA filing for our clinical proof of mechanism data, and we'll be expanding into indications and moving on to the next phase shortly. So I know that was brief, but I hope that's just given you an insight to the company. If anyone has any questions after, feel free to come and speak to us.
¿Tenéis preguntas? Es un ensayo clínico que está avanzando en fase 2.
Sí, hay casi
Congratulations to all Alnylam team to be able to apply such a Nobel Prize in different clinical scenarios, in amyloidosis, hypertension, and now for HHT. So it's a great goal, a great new therapeutic approach to treat these patients. And my question is simple to perform, but maybe difficult to answer, because this type of RNA inhibition is always needs to be administered every 3 months, but independently of the protein, the target protein, and independently of the disease. So do you think that maybe those modification of this approach could have different results in patients in maybe HHT or hypertension or amyloidosis?
So sorry, about...
So a different type of dosage in these patients.
So
The frequency of the dose administered in every patient.
yeah, so we'll be working out the dose frequency see as we get through the later phases. But I know with some of our approved drugs, yeah, they can be every 6 months or every 3 months if they have an injection. So, yeah. Does that answer?
Yeah. Okay. That is difficult to, because we don't have so much data to
Not right now,
Yeah.
but yes, on the approved drugs, it's, yeah,
Okay.
to either every 3 months or 6 months with the ones currently on the market, but we have to obviously do the trials and make sure that the dose we're giving is in the right interval.
Thank you very much. Congratulations.